So good afternoon and aloha. My name is Eric Barsatang, and I oversee the physician relations and medical staff services here at the Queens Medical Center, West Oahu. The title for today's Speaking of Health is Hand and Wrist Tendinopathies. Right now, and throughout the presentation, if you could ask all our viewers to be on mute, and if you have any questions, please text your question in the chat box, and our speaker will answer them at the end of his presentation. At this time, I'm honored and privileged to introduce our speaker, Dr. Edward Chan, who is one of our orthopedics hand surgeons here at the Queens Medical Center, West Oahu. Welcome, Dr. Chan. You may now proceed with your presentation.
Okay. All right. Thank you, everybody, for being here. So we'll talk today about hand and wrist tendinopathies. So to kind of start at the beginning, what is a tendinopathy? It's basically a condition affecting a tendon. And what exactly is a tendon? A tendon is a fibrous connective tissue that attaches muscle to bone. So that picture you see there shows kind of the most simplistic version you see there. The muscle is what powers your movement, and it attaches to your bone via the tendon. That's kind of the white, thick substance you see there. So when you contract a muscle, it pulls on the tendon to help you pull on the bone, and that's ultimately what allows you to move all the different joints of your body. So you have multiple tendons throughout your body, and of course today we're focusing on the ones in your specific ones in your hand and wrist. Now there's many tendons that can get issues in the hands and wrists, but the most common ones are these two that we'll talk about today: trigger finger and another one with a fancy name called the quervain tendinopathis. Just so you know, there's other tendon issues we probably won't talk about today that are usually not as common and usually don't end up needing necessarily surgery. But these two are the ones that kind of we see more commonly that end up having to be treated. So both trigger finger and the quervain tendinopathis are examples of something we call stenosing tenosynovitis. That's a fancy word for, or fancy term for saying there's a mismatch between the size of the tendon and the sheath that's overlying the tendon. A lot of these tendons will travel in sheaths, basically like a sleeve that the tendon runs back and forth inside. So that's what the sheath means. And so for some reason, sometimes these sheaths can get kind of tight. Too tight, the tendon just kind of gets stuck going back and forth in there, and that can be the source of symptoms. So for example, trigger finger, again, is probably the most common tendinopathy we see in the hand. This involves the flexor tendons. The flexor tendons are the tendons that are, you have a set of them in each one of your digits, so your thumb and each one of your fingers, and they help to bend the fingers and the thumb. So in the picture you see here, the tendon is that black, long kind of rope looking structure next to the bone. And you can see all those multiple white structures, which are bones. And so that tendon it pulls on the bones. The tendon actually attaches to the muscles in your forearm. And so when the muscles in your forearm fire, they pull on the tendons to pull on those bones, and that's what allows you to flex your finger and your thumbs down. So these tendons travel within these sheaths, as we mentioned before, and specifically in this location, they're called pulleys. So you can see one of the pulleys is labeled there. It's at the base of the finger in that picture, and that's where the culprit usually is for this condition called trigger finger. So the pulleys, again, hold the tendons close to bone, just like it says, they're like a fishing rod, keeping the tendons close to the bone to allow for movement. And so in trigger finger, what happens is that sheath gets too tight, that pulley gets tight, the pulley becomes thick also, and the tendon itself gets swollen from all the irritation and pain from the friction, with that. If you imagine that tendon trying to glide through that sleeve or that pulley, every time you try to bend your finger up and down, if it's too tight, it just causes pain and irritation. And so the tendon itself gets swollen. You can see on the picture there's a nodule now, in that tendon because it got swollen from all the irritation. And so ultimately, what happens for a lot of people is when they bend the finger down, like in that picture, on the way up, trying to straighten the finger out, that swollen nodule is having a hard time gliding through that thick, tight pulley again. And sometimes usually it finally does, it just kind of snaps and does what we call triggering, and it causes pain and it causes that triggering sensation. And sometimes it gets so bad that it gets, locked in a downward position, and people can't straighten their finger out unless they pull on it with the other hand. Or sometimes it's stuck on the other side of the pulley where it's just straight and they have a hard time bending it down. So again, this issue causes catching or triggering and sometimes locking of the finger. So that picture here you can see shows someone with a finger that's locked because that nodule is now stuck on the other side of that sheath and it has to fight its way to get back through. And the symptoms are often worse with activities. A lot of people will say as they're gripping tightly, as you can imagine, it can elicit the symptoms, make it worse. Or first thing in the morning is a very common complaint too when people wake up. And the thinking is that most of us when we sleep, we're probably, clenching our fingers a little bit, curling our fingers up without, consciously knowing so. And when you're doing that all night, it just has a higher chance of getting stuck like that when you wake up in the morning if you have trigger finger. The symptoms again include pain in the palm at the base of the finger or thumb, where the pulley is. So it gets stuck, but it also tends to cause pain in that area. Some people with mild or early trigger finger, or what we call sort of atypical presentations, some people may not even have the triggering or the locking, but they simply have pain in that area every time they move the finger, and they don't know why. And so, with our physical exam in the office, we're with our experience and our knowledge, we can kind of help diagnose that sometimes, even if someone's not actually having trigger finger. I do see that not uncommonly is people, have the diagnosis of trigger finger, but they may not be showing the actual triggering. They may just be having pain in that area. And again, they may not be frankly triggering or having the locking, but just limited range of motion, just not, just a sense of stiffness, difficulty kind of bringing it all the way down because of pain. Even if you're not triggering, that can be also caused by trigger finger. And a lot of people ask, well, why did I get this? And, the natural tendency for us as humans is to try to think, well, what did I do? How did this happen? Was it from, my job, working a certain way? Was it from an injury? The reality is we don't know. There's no known cause. Trigger finger is very common. A lot of people get it. I tell people in my office, all kinds of people get trigger finger. Kids, I guess, is a different entity. So we'll ignore kids for now. But in terms of adults, young adults, older adults, all age groups, all different kinds of jobs, all different kinds of backgrounds, people who use their hands a lot, people who don't use their hands and just sit on their butt all day and, say they're sedentary, different shapes and sizes of people. Anybody can get it, and we don't really know the exact cause. It's considered multifactorial. So I tell people, don't stress about, it's not your fault, nothing you could have prevented necessarily. If it's going to happen, sometimes it's just going to happen. There are some conditions that are often more associated with having more trigger finger, things like diabetes or rheumatoid arthritis. Those patients can tend to have more trigger fingers or trigger digits, but people without those conditions can easily get the same trigger fingers as well. And so, how do we treat this problem? Standard things that people will list, in the beginning, they'll always list splints, anti-inflammatory medications, sometimes therapy. These are kind of routine things we always discuss. So the reality is that these top three things don't tend to help that much for most people unless it's a very mild case. So splints, for example, would be like in that picture there, something just to kind of hold the finger straight to prevent it from bending down and getting stuck. And that usually is most helpful for people who, maybe have a mild case where it's only happening when they first wake up in the morning. I tell them you can try wearing a splint at night when you sleep. That way you're not unconsciously or subconsciously curling it up all night. And that may help it not get locked in the morning. But the problem is it's not really practical to wear this kind of splint all day during the daytime because otherwise your finger will end up really stiff. Fingers get stiff very easily. We don't like people to immobilize for too long. So unless you're only having sort of mild nighttime symptoms or just, occasional daytime symptoms, it's not really a great solution to wear these splints, all day to try to make it go away, in my opinion. And typically for a lot of people, it just doesn't really make it go away anyway. Anti-inflammatory medications, things like Advil, ibuprofen, Motrin, things that say, the medicines that say anti-inflammatory on the bottle, those are always very reasonable to take because there is thought to be a component of inflammation involved with this condition, and it can that can lead to pain. So it's not wrong to take anti-inflammatories like Advil or ibuprofen or Motrin, and actually is a good idea to try to help to take it to try to help with the pain. But again, the reality is just that it hasn't been shown to really help make the condition fully go away. If you have a mild case, you might get lucky; it might go away just with the medications. But something to try, but not a great long-term solution for a lot of people by the time they see me. And then some people ask about, therapy. I'm a big fan of hand therapy. It's like physical therapy. Some people are more used to that term, but we call it hand therapy or occupational therapy that focuses on the hand. I'm a big fan of hand therapy for a lot of conditions, but this is one condition where it just doesn't seem to be that helpful. As much the therapist can only do so much, but it's an anatomic problem where there's a mismatch again between the tendon getting stuck in that sheath. So, if people really insist, I can send them to therapy to see what it does. But the reality is, again, it's just not that helpful. So we don't typically do it very routinely. Most people, by the time they see me, they're very bothered by their symptoms, very annoyed. And so the best thing to offer them is a steroid injection. And so what that is injecting steroid medication directly into that area, pictured before around that tight pulley. And steroids are basically powerful, anti-inflammatory medicine. So by putting it directly in that area, it can calm the inflammation down, kind of loosen up that area around the sheath. And a lot of people do very well with injections, which we'll talk a little bit more about later. But that's usually the first thing we try in the office. And for some people, that's it, one shot and they don't come back. And it can actually make it go away forever for a lot of people. But it's hard to predict. Some people will have, symptoms come back, or the shot may not get rid of all of it. Usually we'll try at least a couple shots if needed. And the last step I tell people is if it's not going away with shots, you're better off just having a surgery for it, and because the too many injections can be harmful too. And at some point, it's just futile if it keeps coming back. And the good thing is the surgery for this is actually very simple, which we'll talk about more later. It's a very minor, small procedure, easy, same-day thing with usually very satisfying results. And so that's another reason why we have a low threshold to say, hey, if this keeps coming back with shots, it's not going to go away. If you just keep doing shots, you might as well just have a very simple surgery and just get rid of it. So again, splints, the studies out there do quote sometimes 40 to 80% success. So I guess, some studies show kind of a higher success rate there, but just, anecdotally, I think most hand surgeons and, in training, what I learned was it just not really that helpful. That seems like a kind of a high number to me, but you can always try that. Anti-inflammatory medications and again, therapy, that seems like a high number to me, the 69% that's listed in some of the studies. Again, just not that helpful in our experience. As steroid injections and surgery. So with steroid injections, it's usually a 60 to 90% success. And again, most people are, usually satisfied very quickly. They notice the pain go away and the triggering go away pretty quickly. And the shots are very low risk too. We do them all the time in the clinic. I do tell people the main things to be aware of, there's always a theoretical small risk of an infection anytime you are sticking a needle in something with any kind of, shot, but that's a very, very, very rare chance. You can get something called a flare reaction sometimes with a steroid injection. And what that means is the body's, the way the body reacts to the steroid medicine and the shot itself. For some reason, sometimes it just causes localized sort of irritation and pain. I sort of think of it like, when you get a vaccine, how sometimes your whole shoulder just gets painful and sore for a couple of days. So I tell people, unfortunately, some people do get this flare reaction where it can potentially hurt worse for a couple of days, but most people don't get it. And then it's just temporary usually anyway. And then one other potential side effect, I just kind of warn people about the shot, is it can cause some kind of mainly cosmetic kind of changes in that area. Sometimes the skin can kind of turn a little whiter or lighter. There can be something called fat atrophy where the tissues underneath the skin just kind of thin out a little bit. So it just feels like things are kind of thinner in that area. That can potentially happen too, but they're in general pretty minor side effects. And then that the skin hypopigmentation and fat atrophy, they usually are just temporary, but they can last many months sometimes. And again, after the shots, unfortunately, recurrence is not uncommon. It can come back, certainly, but it's worth trying for most people because for some people it does go away forever. And the recurrence usually happens more with certain situations. Diabetic patients, unfortunately, do have a higher chance of the shots not permanently making things go away. The longer you've had the trigger finger, so longer duration of symptoms, also puts you at higher risk for the injections not being a permanent solution. And then having multiple fingers involved also is a risk factor for the recurrence after getting a steroid injection. But again, if it keeps coming back, it's a very simple surgery. I always tell people this is not a bad problem to have. It's very treatable, and it usually goes away forever afterwards. It's not as difficult as something like arthritis. Some people come to me and the issue is arthritis, and I tell them that's a more complicated issue to treat because there's harder, you can't really cure arthritis. There's harder surgeries that you have to do to try to control the pain. This is very simple. So when everything else fails, we just do a surgery, and it's basically it's called a release, where we release the tight tendon sheath or pulley. So that picture there, you may be able to see, it's similar looking incisions, maybe not quite so big as that, maybe a little smaller, but you can see in the picture over there, over the thumb and over the pinky finger, they're basically exposing that tight band. Again, it's like a tight sleeve on top of that tendon. And we literally just open that band up and unzip it. And if you remember back the other picture before, there's multiple pulleys along the finger. So you don't really need this one there. Some people ask a good question, why do we even have it? It's just, I guess, part of our anatomy. But you don't really need to have it there. It can be released open, and the other ones, work fine. I kind of think about it like, I tell people it's sort of like, in my mind, like unzipping a sausage casing, a tight sausage casing, and then everything just kind of pooches out and can breathe. I kind of feel like it's the same way when we do the surgery. When we unzip this tight sheath, it's actually usually very satisfying. You can tell things are just kind of opened up and not so tight, and the tendon has more room to breathe in that area. So it's very satisfying. Again, it's a simple procedure. Usually for most patients, we just use local anesthesia without having to go to sleep. We just do a numbing shot in that area, and that's enough to usually numb it where there's no more pain, and people can have the surgery done with no pain after that. So a little bit of pain from the shot, I tell people, and the medicine can burn a little bit from the shot. But after that, once that sets in, there shouldn't be pain. And so that's nice because you can avoid having to be put under. You don't have to necessarily fast before surgery. And one benefit for us as the surgeons is in the surgery, after we're done releasing it, because you're awake, we can actually test the surgery. We have you bend the fingers all the way down to make a fist and open up all the way. Of course, there's no pain when you do that because it's numb. And that way we can confirm multiple times with you bending it down, going up, that it's not getting stuck anymore. And that's always more accurate than if you're asleep and we test it, passively ourselves moving it. That's just not as accurate as you doing it yourself. So that's one benefit of doing it under local anesthesia only as well, is to be able to test the release. It's a very low rate of major complications. There's always the usual potential complications with surgery, like infection, which infection can be serious if one gets an infection, but the percentages are pretty low. It's probably not more than 1%, I tell people. But unfortunately, nothing is 0%, so it is always possible. But in general, it's a very low rate of any kind of major complications. The main things afterwards that people mention are, it is sore for a little bit. Everyone's different based on their pain tolerance, but sometimes the soreness there can last, for a few months. Usually it's not debilitating, but you may just have a little reminder of some mild soreness there. And then recurrence is rare. After this procedure is done, it's very, very, very rare that it would come back. And again, you can see that picture shows an example of sort of what we do in the surgery. It's a pretty small incision, that's basically our little window that we're working through. And that's why it's you can tell it's not a huge kind of procedure. And so, now, it's nice. Queens Medical Center, West Oahu here, they just opened up a brand new same-day surgery center, which kind of makes it nice to be able to do all these cases in an efficient manner too. It's a nice facility for us to do kind of these quick, simple, same day, small minor procedures. So moving on to the next condition, this is called the Quervain synosynovitis. So it's the most common tendinopathy that we probably see in the wrist. And so the tendons, this involves the tendons that cross the wrist and help move part of the thumb. So if you can see on that picture there, it's on what we call the radial side of the wrist, basically the base of the thumb, helps you kind of pull your thumb up. And it's analogous to the trigger finger in that the issue here, again, is this stenosing tenosynovitis, meaning a tightness of a sheath, over tendon. And so in this situation, there's actually usually multiple tendons actually in that one compartment. It's called the first dorsal or first extensor compartment. So it's circled in that picture there. That part of the wrist is where it's too tight, and then the friction and pain there again causes the friction from all the tightness there causes pain in that area. Unlike trigger finger, however, as we'll talk about later, usually the symptom is mainly pain. You don't really get triggering of the wrist. It just doesn't happen here. So people's wrists aren't getting stuck or anything like that, but it's just pain in that area. And again, no one known cause, just like with trigger finger, it's multifactorial. But for this one, repetitive motion is thought to contribute. People who kind of use their wrist a lot for lifting, maybe for work, kind of a lot of this motion up and down, with the wrist. And then hormone changes are thought to play a role too. This condition specifically is very commonly seen in young mothers, especially during and after pregnancy. The thought is with the hormone changes, there's just more swelling in different parts of the body, including this area. And so that is one demographic that we can often see get this condition. But again, just like trigger finger, it happens in, all different kinds of people, all different kinds of jobs, younger folks, older folks, men and women, all different shapes and sizes, all different backgrounds and such. So again, it's pain to the base of the thumb. We call it the radial side of the wrist is where people get the pain. And especially with activities that involve ulnar deviation. This picture here is showing ulnar deviation. That's the direction that, if you go in that direction, it tends to pull on that tendon and elicits the pain. So one of our exam maneuvers in the office is actually to gently kind of do this maneuver. And if this brings on the pain, usually it helps confirm the diagnosis of de Quervain's tenosynovitis. And similar to trigger finger, I mean, the treatments are actually very, very similar. Again, splints are an option. And again, for many wrist conditions, I am a big fan of trying, splints and braces. But the studies actually have shown for this condition, it's just not as helpful for some reason. Anti-inflammatory medicines, again, can be used. It's very reasonable to take them as needed because there is a component of inflammation usually that's causing the pain. And if you have a mild case, you maybe get lucky and that may help it die down. But again, the reality is for most people, it just ends up not being enough. And then therapy, again, for this condition just hasn't been proven to be that helpful. And then again, steroid injections usually are the most effective thing that we like to try first in the office. By the time most patients see me, they want something to really try to help get rid of the pain as soon as possible and as effectively as possible. And so the steroid shots are the best answer. And specifically, again, there's studies showing that the injections do have a better success rate than splints. And then even if you do a shot and do a splint on top of that, the studies have shown the splint doesn't really add much to the benefit. So sometimes we'll give people splints, if it's sort of the second time getting a shot just to kind of try everything before surgery. But again, the shots usually are the most effective thing to try first. And so some people don't end up even using any splints if the shots help. And similar to trigger finger, some people get one shot and it just goes away forever. Some people get one shot and it can come back or not completely go away. And we may try a couple of shots or a few shots to see. But after a couple or a few shots, once it's clear it's not going to fully go away, then we usually recommend a surgery to get rid of it. And again, just like trigger finger, I tell people this is not a bad condition to have. It's a very simple surgery that we can do to just get rid of the problem pretty definitively. It's a minor procedure. We're not changing your anatomy a lot like we are with arthritis surgeries, and it's usually very satisfying. So again, in this case, steroid injections are very successful, 62 to 100% listed in the literature. Again, splints, you can see the studies show, much lower success rate there, 14 to 18%. And as I mentioned, adding the splints to therapy and injections alone does not improve the outcomes. And again, usually very quick satisfaction with the injections and same risks as with the steroid injections to the trigger finger we talked about. So a small chance of a flare reaction. Always is a chance for skin hypopigmentation and fat atrophy. I would say in this area, because on the radial side of the wrist, it's just a more thin area for most people that the skin is very close to the area that we inject. There's not a lot of tissue there for a lot of people. It is a little bit more common to see that skin hypopigmentation here. Basically, it's sort of a white patch or a light patch of skin there. Again, just sort of a cosmetic annoyance. It can last for a while, many months, but usually not very serious in the long run. And then one thing, just an educational point is that, we simplify things by explaining that there's one sheath where all these tendons lie in for this condition, for de Quervain's, but a lot of times there actually is a separate subsheath for one of the tendons within there. So basically a sheath within a sheath. And that's, good for us to know. This can lead to failure of the injection because when we inject the medicine, sometimes, if there's a separate subsheath, we may not be able to know with the needle whether we're getting into the deeper subsheath for one of the tendons specifically. So that's one thing to be aware of is sometimes a shot may not help all the way and maybe because there's a separate subsheath and there's a higher chance of needing surgery for that. And then this is also a good point to know for the surgeons because that's one potential source of failure sometimes. The surgery usually has a high success rate, but people who don't get full relief after surgery, it may be because there was a separate subsheath that the surgeon didn't recognize. So that's something that I was always taught, is to really make sure you look for all the potential subsheaths. So if anyone has had this surgery before and maybe didn't have a fully satisfying result after a while, there may be a role to go back in and take a look. It's possible the initial surgeon maybe missed a separate subsheath, for one of the tendons there. So again, treatment for definitively making this go away, if everything else fails, is the surgery to release the sheath. Again, similar to the other, the trigger finger is basically snipping open this tight band, this tight sleeve over the tendons, and you can just feel kind of everything getting more air and just relaxing, more without the tightness over it. And that picture there kind of shows you, again, an example of kind of the cut that we do in surgery. Again, pretty small cut, so it's a minor procedure. This can also be done under local anesthesia only. It's not as important for us as the hand surgeons because we don't have to, there's nothing to test here regarding the triggering. So if patients really want to be, sedated a little bit or put to sleep, that's fine. But if they want to try to avoid having general anesthesia, doing this under local anesthesia is very doable. Again, a very low rate of major complications. Same, small risks of infection, just like with trigger finger, and some soreness for a while after that in that area. In this surgery, I would say there is more likely chance of temporary numbness. That is common because there are some nerves that run in that area that supply sensation to sort of the back of the hand here. They run right across where we have to do our surgery. So for us as surgeons, one of the most important things is to protect those nerves during surgery. So we don't want to cut the nerves. If we cut the nerves, then you could end up with permanent numbness and usually pain, but we don't want to cut the nerves. But I tell people, ironically, to protect the nerves, we actually have to kind of move them aside. And by moving them aside with those retractors you see there, they do get stretched out a little bit, unfortunately. So nerves are very sensitive, if just by protecting the nerves, by moving them away, ironically, we do kind of irritate them a little bit by having to stretch them out of the way. So that's why it's common to get some temporary numbness. That usually does go away, can take weeks sometimes, can take months sometimes, but it's usually not, very, it's not usually painful. It's not really that annoying for the patients. Usually it goes away eventually, but that is something that can happen by us actually protecting the nerves. And then again, recurrence with this condition is quite rare. And again, just like before, this is a pretty simple, efficient, same day outpatient procedure. Again, something we could very easily do like in the same day surgery center here at Queens West. So in summary, hand and wrist tendinopathies are very common. The two most common being trigger finger in the hand, and trigger finger causes pain and catching or triggering of the finger, or in some cases just difficulty, flexing the finger down due to pain. And also to Quervain synosynovitis, which is the most common tendinopathy in the wrist, causing pain on the radial or the thumb side of the wrist at the bottom of the thumb. There's no one known cause for either of these conditions. So, if you get it, it's not your fault. Don't worry about trying to figure out why. It's just very common, and all kinds of people can get these conditions. Treatments, again, steroid injections work the best as a first option that we usually offer in the clinic. You can always try other things like splints or anti-inflammatories or therapy, which again, we do like for a lot of conditions in general, but for these, they just don't seem to help that much. And if conservative management, with those things or the shots eventually fail, then it's a very simple surgery that you can do for both of these conditions that works well, very satisfying, low risk of complications, and gets rid of the problem pretty easily. So that's the end of the formal talk that we have here. Thank you to Queens Medical Center West, and thank you to all my partners, my other orthopedic partners in my group, as we all help kind of support each other. Any questions now, I guess?
Yeah, thank you very much, Dr. Chan, for the informative presentation. We sure learned a lot. Yes, right now we will proceed with our Q&A or question and answer portion. Again, if you have any questions, please type them in the chat box right now. And we do have a question in the chat box. And the first question that we have is, will acupuncture help instead of injection or surgery?
So, being trained in Western medicine, with Western medical literature, my knowledge is it's not shown to help with these kind of conditions. So I don't formally recommend it or formally prescribe it or anything like that. That being said, in Eastern Asian countries, they may have different, biases in research because that is more prevalent there. What I always tell people, I think acupuncture is probably not harmful, unless, they use a dirty needle and you get infected or something. In general, it's probably safe. So you're always welcome to try acupuncture. And if it works for you, great. If you find something that makes it go away, great. But yeah, officially, I don't usually formally recommend it. We can't, I have no, strong literature to support that it will make it go away.
I see. And the same person did have a second question. And the question is, does Dr. Chan have any hand therapy exercises to share for preventative measure?
Yeah, unfortunately, there's, again, no known cause for these conditions. So I would say there's no real exercises to necessarily prevent these from happening. You could exercise and move your fingers and wrists all you want. And yeah, nothing's proven to prevent it in that sense. But I would say for the wrist issue, the de Quervain synosynovitis, if you start to notice pain on this side, maybe early de Quervains, it's actually not exercises, but actually just kind of resting it is better. Just avoid doing things where you're lifting this way. That's a problem with young mothers. They tend to get it because of the pregnancy, and then they're constantly lifting baby up like this. And so I told them, trying to turn your hand this way, more palm up, where you're not bending your wrist kind of in this, like the hammer fist motion is what you want to avoid if you start noticing those symptoms. So that's the one thing I would say is if you notice pain there, more avoiding that can be potentially helpful. And it may still progress despite that, but that more so than doing any special exercises.
That makes sense. The next question is, this person did broke their wrist 2 years ago and still unable to lift anything more than a few pounds. So she's asking if there's anything that she can do about it.
Yeah, that's a complicated question. I think that's something that's a case by case basis. If you happen to have one of these, conditions like de Quervain's, that hopefully would be easily treatable. But yeah, with that kind of history, that could be a variety of different things. Could be the way, the bone healed or something. So that is too hard to answer just in a, without, seeing the specific case and all the details. So that's something that, we could always see you in the office and do a full evaluation and take a look. And, but that usually is a more complicated kind of workup.
Yeah, look like we have a question regarding post-surgery. What does recovery looks like for patients, restriction, time frame, pain medication, etc.? And also there was another question that was brought up earlier, along the same lines. They also talk about post-surgery, if there's going to be physical hand therapy.
Yeah, so good question. So after both of these surgeries, the nice thing is usually we don't have to mobilize anything. We actually want you to move the fingers right away because we don't want you to get stiff. So after trigger finger surgery, I tell people right away, start going all the way down, all the way up, try to exercise it. It may be a little sore, but it's good to work on it. There's no reason to hold back. And so we try to encourage people and teach them to move it. And if, most people, if they can get their fingers all the way down, all the way up, by the time they see me for the first post-operative visit at around 10 to 14 days, then usually no formal hand therapy is needed. But so it kind of depends for the therapy question for trigger finger. And then some people, if they're just struggling, if they're having a hard time bending all the way down, especially, if we did multiple fingers, it can be more difficult. On a case-by-case basis, we may recommend those people do therapy to help them kind of move the fingers better. And then for both of these conditions, we say, the right away sort of light activities are totally fine. Movement's good. So texting, typing, I say probably lifting a coffee cup is a good, place to start in terms of lifting. But we, kind of common sense, avoid heavy lifting, heavy pressure over any of the surgical sites. You probably don't want to lift too much because of pain anyway. So usually, if you do a texting job, a typing job or an office job, you could potentially go back to work, within a week if you, are having good pain control. Certainly within a couple of weeks. But it can take a while to feel comfortable doing heavier stuff. So heavy gripping, heavy squeezing, that kind of stuff. It may take 4 to 6 weeks to feel comfortable doing that. So someone like a construction worker, I think, usually more, maybe 4 to 6 weeks kind of estimating before they feel comfortable doing that. But everyone's different, by the first post-op visit at 10 to 14 days, if you're feeling great and your pain's well controlled, you can really do whatever you want. It's just your pain that can limit you. And then for the wrist surgery for the de Quervain's, we don't immobilize the wrist afterwards either. We let people move it right away. And so, usually the recovery is not that bad, basically.
Okay. In terms of non-surgical treatments, how would you know when a treatment is not working? How would you know when you have to see someone like yourself?
Well, I mean, if you're having any of these symptoms that we discussed, you could always try, some anti-inflammatories on your own, like, over-the-counter Advil, ibuprofen, those kind of things. If you want to try to, try your own splints, you can. Like I said, it's really not that helpful for a lot of people, so I don't want to encourage everyone to go spend their money. You might feel like you're wasting your money on splints, but if you really want to try, you can. But I would say, yeah, at that point, if it's not going away, then you might as well come in and see us, because the steroid shot is what we can offer that usually helps a lot. So if it's not going away with simple things like the anti-inflammatory medicines and resting it, then yeah, I would recommend getting evaluated.
But how long should they try those treatments? Like a few weeks or a month?
There's no harm, I guess, in waiting longer. Unless, I guess, yeah. I mean, I guess a lot of it is just, naturally you're not going to want to tolerate it too long anyway. That's what ended up happening. So I would say, I guess give it like a couple of weeks or so, if I had to, give an answer. But, if it's been a week and it's just miserable, then yeah, come in sooner. You don't have to wait 2 weeks necessarily. It's definitely reasonable to try a shot at that time, I guess I should say. Yeah. So any time is fine. But yeah, I would say by 2 weeks, if it hasn't gone away, it might come in. But it's hard because every case is different. There's a whole spectrum, right? So if it's been 2 weeks, but it's very mild and, you want to wait it out, that's fine. Some people, they, just kind of, I get it. They're scared of needles, scared of shots. Nobody really loves getting shots. So if you can want to wait a little longer and tough it out, but it's hard to say. Yeah, there's no one exact answer, I guess I would say. But I would say by 2 weeks, or 4 weeks, a month, if it hasn't gone away, yeah, you probably should come in. I would say for the trigger finger, if your finger's starting to get stuck in one position where you can't straighten it out, that's when I definitely would come in, because in that situation, leaving it too long can just make further treatment a little harder to be successful.
Very good. The next question do I have look like this personal question. Wrist pain and tingling from wrist to the fourth finger. What should I do? It's been happening a lot recently.
Yeah, so numbness and tingling usually is a different problem. That's usually not trigger finger or decurvence. That's usually from something called carpal tunnel syndrome, which is sort of similar in that it's an issue with tightness, over this part of the wrist, but it's affecting a nerve now. So you can also try simple anti-inflammatory medications, again, like Advil or ibuprofen. In mild cases, they may help. One of the things we'll tell people, if that's a diagnosis, carpal tunnel syndrome, you can always try getting a wrist splint or a brace to kind of keep your wrist straight when you sleep. The reason is if your wrist is stuck like this for too long or this for too long, it will make any kind of nerve problem there worse, like a carpal tunnel syndrome. So just consciously avoid bending for too long this way or bending for too long this way. When you sleep, you can't really control yourself because you're asleep. That's why we have you wear the splint to try to hold it still in a straight position. So assuming that's, if it's carpal tunnel, that's what I would normally do. But again, you can always come and have, a hand surgeon evaluate it. And that's how we would normally start. If it's very severe, we might do shots. And there's also surgery for that too, which is also very simple, satisfying surgery. So that's also a very common condition we see that can be very easily treated.
Thank you, doctor. And the next question regarding insurance, and you may not be the right person for them to ask this question, but anyway, the question is, they're assuming that insurance would pay for the surgery, but do you know any cases where they won't pay for the surgery?
Yeah, not that I've heard, and I'll admit, as you kind of alluded to, I'm not the expert on the insurance side of things, but I mean, these are very common conditions. We treat them all the time. I think normally if an insurance will deny the surgery, my office will tell us, and we can't do the surgery. I can't remember that happening for these conditions. I really don't. So I think that'd be super rare. I think if for some reason, the surgeon, it just doesn't know what they're doing and they put the wrong diagnosis and it doesn't sound like what's going on, maybe, but I mean, that'd be super rare. I think as long as the diagnosis makes sense and the notes make sense, yeah, I think it should get approved by most insurances.
Yeah, excellent. In terms of surgery, regarding scarring, does that affect the overall success of the surgery?
Yeah, anytime you do surgery, the body naturally will make scar tissue. And I tell people it's not just the skin where you see the scar, but it's every layer you cut down. So there's often scar tissue internally. And so everyone does scar differently. That being said, most people, especially for these kind of minor procedures, the internal scar tissue is not that bad. So for most people, the answer is no, not really. There can be scar tenderness. That is very common, where it's a little sore over the scar, but that usually goes away, and most people's scars fade away pretty well. So for most people, no. But for some people, yeah, if they, for some reason, kind of develop more scar tissue for some reason, whether it's internally or on the outside, they may end up having some more sort of, tenderness from that. But for most people, I would say it's usually not a big issue. I do tell people with any surgery you have, you will have scar tissue on the inside as well as the outside. So it shouldn't bother you much in terms of pain, but you may always notice, just that area might, feel a little thicker, a little bit more swollen, maybe slightly. I think it's psychological too. You had a surgery there. So if you always kind of look at it and mess with it, you can tell something's different. So sometimes people kind of fixate on that and say, hey, it's just that, anytime you have surgery, there will be a reminder to your body like, oh yeah, something happened there. There's a little bit of, maybe a thickness or something there, but it's usually very minor for these kind of things.
Thank you. Next question is regarding age factor. When don't you recommend a person should be having such surgery? Or another question here is that when don't you recommend a person not having such surgery?
Well, in terms of age usually for this, doesn't stop us from doing surgery because they're so simple surgeries, they're easily treatable on these conditions. I would say if you're at a certain age and you have a trigger finger, but it's not painful and doesn't bother you and you really don't want a procedure, sure, if you can live with it, that's fine. But if it's making you miserable, then I wouldn't hesitate, because it's a very simple procedure. And like we mentioned, most of the time we can just do under local anesthesia, which really takes away that risk of having general anesthesia, to your body. So, general anesthesia, there's always, some risks, if people have bad heart, that can always potentially cause issues, or, older folks can have, sometimes worsened, dementia or cognitive issues, after general anesthesia, sometimes, not all the time, but you don't have to worry about that if you have, a surgery done under local anesthesia in this case. So, for that, reason, if they want to have it done, I would say for me, there's not an age limit, put it that way. As long as someone wants to do it, and, if they can lie down in a bed and have their arm out and do surgery, then it should be done. If they're so sort of, debilitated that they, can hardly move anything, they're just stuck in bed, I guess, there may always be exceptions, but I have a low threshold to do surgery if needed.
Okay. And the last question that I have here is regarding referral. Would a patient be able to just, contact you directly or your office, or they have to be referred by their primary care physician?
I think that's depends on the insurance, is my understanding. So you can always call the office, like here at Queens West, you can always call the Queens West Orthopedic Clinic. And I think usually the staff there can figure it out based on your insurance. Some insurances you can come to us directly without needing a PCP referral. Some insurances just require that PCP referral. So I think it just depends for each person. Yeah. But I think if you call our clinic, for example, the Queens West Orthopedic Clinic, they can always try to help you answer that question, or, if you call your PCP, they may know too.
Okay, very good. And look like there's a comment in the chat box. I don't see a question. It's more like a comment. My mother is 84 years old, and she recently had trigger finger surgery and carpal tunnel surgery. So hopefully she's recovering. It doesn't say when she had it, but just as recently. Are there any further questions from anyone? I see none. So that concludes our Speaking of Health presentation for July. Again, thank you very much, Dr. Chan, for being with us today. So again, that concludes our Speaking of Health presentation for July. Again, Dr. Chan is our orthopedic hand surgeon here at the Queens Medical Center, West Oahu. Again, I would also like to thank all of you, our virtual audience, for joining us today. Just an announcement that the Queens West Oahu virtual Speaking of Health lecture series is changing to the third Thursday of every other month at 12 noon to 1 p.m. Again, Queens West Oahu virtual Speaking of Health lecture series is changing to every other month, but still the same, the third Thursday and 12 noon to 1 p.m. So the next one will be Thursday, September 19th, and after that will be Thursday, November 21st. So look out for the announcement and information regarding the next lecture. So on behalf of our Vice President of Operations, Robin Kalohelani, our Chief Medical Officer, Dr. Ronald Kuroda, and the entire Queens Medical Center West Oahu, Ohana, mahalo nui loa. Thank you very much again for joining us today. Until next time, please take care and always be safe. Aloha.